Thank you for that introduction. I'm actually, I hope I do justice to this lecture, because this was one of the lectures that Professor Riley was supposed to be giving. Unfortunately, as I said, she couldn't come, but I felt it was such an important topic that I took it on myself to give the talk instead. I don't have any conflicts of interest regarding this talk. And I think Dr. Gottsman gave an excellent introduction to the scope of the problem that we're dealing with, which is just enormous. And just to recap, as he said, we're talking about a disease that affects a huge number of the population, going up with age. The survival is poor, with up to about 40–45% of patients dying within a year after hospitalization, and the huge economic burden he's already talked about, as well as a high symptom burden, which is a big problem, obviously, both for the patient himself and for the family and caregivers. Now, what I'm going to be presenting here mainly is this document that was published a couple of years ago. It was basically by the instigation of the European Society of Cardiology, in particular the Heart Failure Association, to try and galvanize a policy to bring to the fore awareness of the problem, the global problem of heart failure around the world. And it's basically divides into several main topic headings, which you can see here on the left, which we'll go through one by one. And this is a very important document, basically summarizing what's going on. There's another document, a similar sort of document that was prepared looking in particular at acute heart failure, with also various policy recommendations that came out of that document, including some of the things that Dr. Gottsman touched on as well, including transitional care, improving patient education and support, providing equity of care for all patients, which we'll show, I'll talk about that shortly, appointing experts to lead heart failure care across disciplines, stimulate new research, development and implementation of better measurements of care quality, and improving end-of-life care, and putting an emphasis on prevention. These are all the things that Dr. Gottsman mentioned. And how can these be achieved? Well, through three main modes. First of all, education of the professionals themselves who are out there in the field dealing with the heart failure patients, and also, as much as possible, educating the health policy makers. They need to sit up and be aware of the burden that all the health systems are dealing with. We need to promote advocacy, building coalitions, including the patient and the patient's carer and the professionals, and activation of all the mechanisms to get things working, implementing them, disseminating the information and different models of care, and importantly, also monitoring the quality of the work that we're doing. Now, the first heading is promotion of heart failure prevention. Now, it's very interesting, actually. If you talk about heart failure, what does an average man in the street or woman in the street know about heart failure? And this has actually been looked into. There's a couple of studies. One of them was published about 10 years ago, looking in 9 European countries, taking a random sample of about 8,000 people and asking them what they know about heart failure. And as you can see here, over 80% of people, this is a graph on the left, over 80% of people said they'd heard of heart failure. But when you ask them, this is just a very short synopsis of the findings, only about a third of them said it's something that happens with age. That's all it is. Almost 50% of people knew what the symptoms of a stroke are, for example. And about 30% knew what the typical symptoms of ischemic heart disease are. But if you actually ask them what are the symptoms of heart failure, what do they actually suffer from, you can see a tiny number of patients who, a number of people who actually know what heart failure actually is. They've heard of it, but they don't know what it actually means. More recently, just a couple of years ago, there was another smaller study published in Slovenia, from Slovenia, looking at about 850 patients, again, doing a sort of random sample and seeing what they knew about heart failure. And about a third of them, again, thought it was just an age-related problem, not actually a disease. And about a similar number felt that it was actually just something that you treated just by resting. So we actually need to boost the public awareness of the disease, which is one of the reasons we're holding meetings like this. And there are many ways of going about it. First of all, the ESC, the European Society of Cardiology, have a website which is actually very, very interesting if you should all go in and have a look at it. By the way, they have it in different languages as well. It's called heartfailurematters.org, which explains about heart failure to the layman. It's not supposed to be a medical thing, it's more for patients and families. But there are lots of other initiatives that can be promoted on national or local levels, including education forums for public or professionals, activities in school, lobbying of governments, local media activity, etc., etc. It's one of the reasons, by the way, that the Heart Failure Association of the ESC started several years ago what they call the Heart Failure Awareness Day, which it's actually more than one day, it's a few days, usually around about this time actually, and that's one of the reasons we're having the conference today, is that it's just about this period of time where across most of the European countries, all the ones that have an active heart failure association, there are all sorts of activities that are promoted to try and boost the public awareness of heart failure in general and heart disease on a global scale. And this is one of the events we're holding to that end. So a lot of things can be done about it. People need to be made aware of the complexity and how common it is, and as Dr. Gottsman showed, it's actually more common and more deadly than most forms of cancer. And if you ask do a sort of random survey of women, you ask them what they think they're likely to die of, and most of them will say they're probably going to die of breast cancer. In fact, heart disease kills more women than all cancers combined, and people generally don't know that kind of thing. So, how can we promote heart failure prevention? All the typical cardiac or cardiovascular risk factors have already been mentioned, and basically the challenge is to try and identify and manage the patients who have this increased risk. There are different ways of going about it. This is one study that was published a few years ago, looking at centres in Ireland, where they looked at about 1,300 patients with various cardiac risk factors. These weren't patients who have heart failure or have established heart disease. They just had some kind of cardiac risk factors, and they were divided into groups where some just had normal follow-up care, standard treatment of their risk factors, and others had some kind of basic screening, where the basic screening was doing BNP level, B-type natriuretic peptide. And those who had a BNP above a certain level were then sent on to do further investigations, such as an echo and very intensive risk factor management, regular cardiology follow-up, specialist nurse in contact with them to keep a follow-up on them, review of their medication and their adherence and their lifestyle modification. And basically what they found was that if you look at patients who went on to develop left ventricular dysfunction, more of them developed left ventricular dysfunction in the control group. That is, the patients who didn't have the intensive follow-up with the BNP levels and echo screening, etc. More of them were found also to have asymptomatic left ventricular dysfunction. The hospitalization rate for MACE, for major adverse cardiovascular events, was almost double that in the control group compared to the ones who had more intensive follow-up and based on screening. There wasn't any particular difference in terms of change of biochemical risk factors. There was an increase in prescription of drugs affecting the renin-angiotensin-aldosterone system. But in fact, if you look at the overall heart rate, blood pressure, etc., you can see here that in the blue is the control arm, the red is the intervention arm. These are the intervention arm, the ones who had more intensive follow-up and investigations with echoes and BNPs. You can see that the intervention group certainly got more ACE inhibitors, ARBs, etc. But in fact, in terms of blood pressure control, it was just as, at the end of the day, it was reduced to the same extent in the intervention group as in the control group. Similarly, the heart rate was similar in both groups, meaning they both got the same amount of beta blockers, which you can see here. And the LDL levels also reached about the same levels in both groups. So even though most of the risk factors were fairly well controlled in the control arm as well as the intervention group, just the fact that they had more intensive investigations and screening reduced the combined rates of left ventricular dysfunction and heart failure. Another smaller study done in Australia looking at nurse-led interventions for heart failure looked at patients who were discharged after cardiac admission with regular nursing follow-up within about a week or 10 days of discharge and after a month, where they had more intensive individualized management of risk with online education or telephone education by the nurse and coaching with follow-up for 4 years. They didn't actually find a difference in the rates of hospitalization for heart failure or death, but there were fewer days spent in hospital because of heart failure. And if you actually looked at cardiac function over a long term, there was less reduction in cardiac function, ejection fraction, in the patients who had the nursing follow-up. One other important factor, which is also something that Dr. Botsman hinted at, is the problem with, and this gets onto one of the things of equity of care, etc., is that there's actually a very, very strong correlation between somebody's social status, level of social deprivation or facilities, and the development of disease. Obviously, people who are more socially deprived have lesser means in terms of risk factor modification, less education in knowing what to do, how to deal with themselves, and probably less money to buy drugs. And you can actually see here on a study that was done in England, actually looking at admission rates, patients who, the sort of scale that was drawn up, looking at levels of social deprivation, and you can see on the far right side of the screen, the patients who had more factors reflecting more severe social deprivation were actually admitted for their first heart failure admission of almost 5 years earlier in terms of age than patients who had much better social circumstances. Next point is to try and improve healthcare awareness amongst professionals. Now, one study that was a survey that was done published in Europe, looking at cardiology admissions on cardiology departments for heart failure patients, and looking at the sort of the drugs that patients were receiving on discharge, and it was actually very encouraging, and there was fairly good compliance with guideline-based therapy. And you can see here that about 90% of patients were discharged with beta blockers and ACE inhibitors or ARBs, about 60% with mineralocorticoid receptor antagonists, and about 80% with diuretics. The blue is the total number of patients, the red are reduced ejection fraction, and the green are those with preserved ejection fraction. So in general, most cardiologists know what they're talking about, which I suppose is fairly encouraging. If you look at general practice, that's a bit more of a problem. This is a study that was published in America, looking at missed diagnoses that GPs managed to miss in patients. Some of it obviously may have been from problems with diagnostic abilities, but basically the second most common misdiagnosis was decompensated heart failure, almost 6%. So there's also some education needed. Nursing. Okay, well look, these were studies that were done looking at cardiology nurses, assessing what they knew about how to advise patients on self-care. And there are two studies published from the States in different points in time, and one from Cyprus. And you can see that the scoring, the knowledge of the nurses had, cardiology nurses, to actually advise patients on how to look after themselves from a cardiac point of view, fell way below the expected level. There's another interesting study that I wasn't aware of that's extremely relevant, and this isn't specific to heart failure. This was a large survey that was done in Europe looking at over 400,000 inpatients in 300 acute hospitals in 9 different European countries. And this wasn't heart failure, this was also including surgical admissions and stuff like that. And what they found basically is that if you had a system where 60% of nurses had a bachelor's degree in nursing and were looking after an average of 6 patients on their shift, then the mortality rate, the in-hospital mortality rate of the patients was 30% less than nurses where only 30% of them had a bachelor's degree and were looking after 8 patients on their shift. So nursing staffing levels and nursing education is critical in the management of patients in general, not just in heart failure. So how can we overcome these gaps in knowledge and how do we educate people? Well, we need to build systems to embrace all healthcare professionals. You obviously need to adapt whatever system you're having to local resources and increase the awareness between the professionals, what each one has to do, making sure that you follow the patient pathway from the very early stages prevention up to palliation and other important points. Next point is to ensure equity of care, making sure that all patients have the ability to get to who's going to look after them best. Now this is actually very important because it shouldn't really matter where the patient actually enters into the medical system with heart failure. On the left side, you may have a patient coming in with florid pulmonary edema into the emergency room, being admitted into a cardiology or a general medical ward. At some stage, hopefully, as well as being treated by a general physician, he'll be seen by a cardiologist. On the other side, the patients with milder symptoms who will be seen on an outpatient basis may be initially assessed by their general practitioner and then referred to a cardiologist in an outpatient setting or to some kind of heart failure clinic. But right at the bottom, basically, we need to make sure that at some stage all the patients will be exposed to a proper professional chronic heart failure management service, which may be in the community or may be hospital-based. But everybody should try and get there. Another point to make is about equity of care is in the diagnostic tools that we have available. And these aren't available everywhere. In fact, a survey that was done a few years ago looking at different European centres, what do we have available? Now, if you look at natriuretic peptide testing, in only about 45% of the countries that were looked at, the BNP testing is available in over half of the hospitals. Here, for example, in Israel, we don't have it as a routine test. We do have access to it, but it's certainly not thought of as a routine test. On the other hand, about 75% of countries did have access to echo performance in over 50% of cardiology centres. So there's a big variation of availability to these tests, screening tests or follow-up tests across different countries, within countries in different areas, and obviously there's a big variation in the waiting time for these tests. Another point to make, if you look at the table on the left side of the graph here, is the sort of drugs that patients are getting when they're in hospital. This is another, these are results from a survey that was done in England. In general, the medical wards have a fairly good percentage of giving the right drugs to the right patients. They're still falling short of the standard cardiologist's level in terms of percentages of patients getting the right drugs. Another very important concept that's been raised in this document, and we'll hear a lot more about it shortly, is what's called a seamless transition. This is basically trying to make sure that a patient who's hospitalized gets back into the community as smoothly as possible with no bumps on the way. And this is another thing that Dr. Gottsman has talked about, where there's good communication, very early follow-up of patients who are discharged, and good communication between the hospital team and the community team, so the patient will continue a very smooth transition back into his native setting. And this was looked at also in a European survey a couple of years ago, and about 75% of the countries that were polled did have a heart failure management program, and about 72% of those, had a heart failure nurse within the team. So this isn't a universal phenomenon. This is the sort of thing that we need to try and attain as much as possible across all countries and all systems. Obviously, there's a lot of variation depending on local facilities, money, government, etc., etc. National regulation of roles of different, the physician or the nurse, reimbursement, and incentives. A study was published a few years ago, about 12 years ago, looking at different trials on the multi-professional team care in in the community and how that affects the outcome of the patients. And basically, they looked at almost 30 different trials, which had encompassed about 5,000 patients. And these were all systems that had different professionals working within the clinic, incorporating also education of the patient for health, for self-care, and access to specialists whenever needed. And there was a definite, very strong reduction both in mortality and in hospitalization for patients who went into a system like this. And hospitalization may be all-cause mortality or heart failure-related mortality. And this has been adopted and actually incorporated into the ESC heart failure guidelines. This is actually a very, very important point where multidisciplinary approach to the heart failure patient with professionals dealing with heart failure need to be in charge of the patients. What about the heart failure team? There's a huge variation across different countries. You can't see the figures here, but you can see roughly according to the graphs, there's very wide variation between different countries in the number of physicians per population, the number of cardiologists per population, or nurses per population, in particular heart failure nurses. And only 55% of countries of those that were checked actually had something that's called a heart failure nurse. And in terms of the number per population, you can see here there's a huge variation. The next point to talk about is support of the patient and empowerment given to the patient and the patient's family or caregivers. There are different ways of going about that. There are lots of different methods and models that have been performed or put into the field to follow up patients and give them support. Some of them may be just sort of telephone conversations with nurses, ringing them up and asking them how they feel. Some of it may be telemonitoring. Some of it may be online communication with some kind of medical facility. But basically the self-care concept revolves around 3 M's. Maintenance, that means making sure that the patient at all stages will adhere to the medical treatment or whatever other treatment he's been getting. Monitoring is a second M, which basically means that the patient has to keep a constant check on what he's doing. You all know that we always tell the patients to follow up weigh themselves daily, check their ankles, etc., and be very, very wary of any change or deterioration. And the third M is management, responding to care. If it's something drastic, then they may need to ring up one of the health team to ask their advice. But very often we just tell them, well, look, if you put on an extra couple of kilos, then increase your dose of diuretic for a few days until it goes down again, and go back to your normal dose level. Obviously, there's some challenges here. Not everybody has access or the right education to be able to perform these things, and there's a lot of social isolation amongst the patients themselves. Some of them don't have a proper social backup to help them to cope with these deteriorations and changes. What's the best way of actually dealing with monitoring and making decisions about healthcare? Well, there's a very interesting Cochrane review that was published a couple of years ago, looking at different models, different studies that were performed on looking at who's the best person to manage a heart failure patient. Should it be the patient himself? Should it be just the physician looking after and giving the orders? Or should it be a joint decision making? Should there be shared decision making? And in fact, what they found was, comparing all the different possibilities, is that all of them are possible and efficacious There's not a lot of difference between them. Probably the best combination is actually to have a shared management program where the decisions are actually made together in conjunction with the physician, in conjunction with the patient himself. And whatever system you use, it's better than not doing anything at all. The final point is promoting heart failure research, which is obviously going on all the time, but it's very important to be aware that we need to keep monitoring the results of the models that we put into use and adjust accordingly if we find things aren't going well. Now, this this document basically was led to a declaration of the Heart Failure Association of the ESC, where all the countries involved signed a declaration form, and where Israel Gotham actually signed on our behalf last year, was it? Last year. And so we're actually an active part of the Heart Failure Association of the ESC, and I think we need to try and adopt the policies here and move forward and get things going in our field. Thank you.